welcome and to the Ambassador Society meeting tonight, and I'm pleased to be able to make a few remarks about the breast program and the Stefanie Spielman Comprehensive Breast Center. Our breast program here at the James started about 2 or 3 years actually after the hospital opened in 1990. At that time, we just had a small clinic down on the first floor of the what we call the old James, and we saw patients there, and they'd be evaluated by surgery, medical oncology, radiation oncology, and any other specialty that we deemed necessary at the time. And really that started our thought process about really developing the multidisciplinary clinic. So about 4 or 5 years later, around 1996, 1997, we decided to really expand the clinic and moved up to Stone Ridge Medical Building in Dublin. And at that time, we had a full-fledged multidisciplinary clinic with surgical oncology, medical oncology, and infusion. The two things we didn't have was radiation oncology and plastic surgery. So we quickly outgrew the building at Stone Ridge and were able to construct the breast center down as where it sits on Olentangy River Road, and really put together a great program and really had all disciplines required to treat breast cancer in the building. It was a 115,000 square foot building, and as I said, had all disciplines represented there. Soon after we opened, we named the breast center the Stefanie Spielman Breast Center in honor of Stefanie, who did develop breast cancer in 1998 and was first treated at Stone Ridge. Really never got to see the breast center because she did pass away, but did leave a legacy. That legacy really stemmed on the ability of Chris and Stefanie to honor her by raising money to fight breast cancer. They put this together in 1998, 1999, hoping to raise $250,000, and today that fund is close to $26 million. So it was a really great effort on their part to start the process of raising money for breast cancer, and it continues today. We're very fortunate to have this breast center, and it's really been a really jewel to help us take care of all aspects of breast cancer. So with that, I will end and turn it over to whoever's next. Dr. Roman Skoracki is now the medical director of the Stefanie Spielman Comprehensive Cancer Center. So thank you very much and take care.
Good evening, ambassadors and friends of the James. Thank you for your commitment to learning more and advocating the work happening at the Ohio State Wexner Medical Center and the James Hospital and Solove Research Institute. It's a pleasure to be hosting this event. I'm Dr. Roman Skoracki, the medical director of the Stefanie Spielman Comprehensive Breast Center and the division chief for Oncologic Plastic Surgery. If you have any questions throughout the evening, please use the question and answer feature at the bottom of your screen, and at the conclusion of the panel discussion, we will answer those questions, time permitting. I want to take a moment to thank Dr. Bill Farr for providing a brief history of how the breast program and the current Spielman Breast Center came into being. More importantly, I'd like to take this opportunity to thank Dr. Farr, who was the original medical director of the center, for his dedication and vision in building the Stefanie Spielman Comprehensive Breast Center into the world-class facility that it is today. Dr. Farr was able to assemble an all-star team of clinicians, administrators, and community leaders to create a truly special place that is able to deliver world-class care to patients with breast disease, where the feeling of institutional sterility often associated with this level of expertise is replaced by a very warm, welcoming, and caring atmosphere that can only exist because everyone shares the same dedication to our common vision. Thank you, Dr. Farr, for all you've done and continue to do for the Stefanie Spielman Breast Center. As I mentioned, my role at the Stefanie Spielman Center is twofold. I serve as the section chief for reconstructive surgery within the Department of Plastic Surgery, working with an expert group of plastic surgeons who I will introduce in a minute. This group delivers the full complement of breast reconstructive options and lymphedema care available. I also serve as the director for the Breast Center to elevate and empower the extraordinary clinical talent in this building, of whom you will meet some tonight. I'm going to ask us to start the slideshow, please. Or move to the next slide, please. Actually, can we back up one slide? Sorry. Some of the things that make us very unique is that we treat more than 1,000 new breast cancer patients annually. We do this in a very large standalone comprehensive breast center, i.e. in a single site of service. We have incredible depth and specialization with our surgical oncologists, most of them doing exclusively breast surgery. Our medical oncologists all being dedicated to breast cancer treatment, and the same being true for the other members of the specialty teams. We have cutting-edge imaging and treating technologies, and that includes a number of imaging modalities as well as treatment modalities that are listed. We perform regional screening and diagnostic reach with our mammography outpatient facilities that are spread around the greater Columbus area, but also with the mobile vehicles that actually reach beyond the reach of of Ohio itself. Very, very important. We have a very robust on-site clinical trials office that handles usually more than 50 open trials at any given time. We have a number of great programs, many of which will be introduced throughout the evening. And we've been recently named the Lymphedema Center of Excellence through the LEARN certification. Most importantly, we have an exceptional culture and patient experience that is exemplified by stellar patient satisfaction scores since really the inception of the center. I think that's what makes our center so unique beyond the access to cutting-edge technology and state-of-the-art facilities is our multidisciplinary care delivered to each individual patient. We run weekly meetings where every individual patient treated at the facility is discussed by all the members of the team to design and optimize the treatment plan. The patient remains at the center of the treatment discussion among all providers that continues throughout their active course and into their survivorship. Tonight, you'll hear from a few members of this all-star team. The order will be loosely follow the path of a patient that may encounter these members as part of their treatment team as they go through their journey with their breast cancer. And I'll ask for the next slide, please. I'd like to quickly introduce the team before we get into the actual discussion. First up is Mrs. Lynn Brophy. She's our adult oncology clinical nurse specialist and an extraordinary educator and bridges the gap often between the outpatient world as well as the inpatient facility. Next is Dr. Hawley, who leads the division of breast imaging, or the section of breast imaging within the Department of Radiology. And you can see him there, backed up by a large team of dedicated breast imaging specialists. Next up is Dr. Tazbikian, who is the division chief for breast pathology with his colleagues. Dr. Doreen Agnes from surgical oncology with her colleagues is going to speak a little bit about the surgical treatment of breast cancer. And next up, we have our group of dedicated radiation oncologists led by Dr. Julia White. Dr. Mingjong Cho is going to be one of my colleagues, is going to be speaking for the plastic surgery group. And Dr. Williams will represent this large group of expert medical oncologists. Ms. Rashay Hatfield represents an even larger group of advanced practice providers within our facility. And finally, Ms. Karen Hawk, who is the Associate Director of all of Rehab Services and also happens to be a certified lymphedema therapist, is going to give us her perspective and round out the evening. Next slide, please. Anything is possible when you have the right people supporting you, by Misty Copeland, an accomplished ballerina. I believe that all of these individuals are the ones that you want supporting you on your breast cancer journey, and I hope that we will give you a glimpse of that journey in the next few minutes. So let's start off on this journey. I will ask Ms. Brophy, our clinical nurse specialist and educator, to give an overview of some of the nursing initiatives at the center and also the breadth and depth of our nursing expertise. Thank you, Lynn.
Thank you, Dr. Skoracki, for that very generous introduction. I'm supposed to tell you about how proud I am of the nursing care at the breast center in 4 minutes, which is basically impossible to try. As a breast cancer clinical nurse specialist, my job is to work with the team to ensure the highest level of quality nursing care. Our 65 registered nurses at the breast center are a perfect combination of caring and expert clinicians and dedicated scholars. They're leaders in the field of oncology nursing. What's even better is, because of our wonderful team, our patients tell us that when they enter the breast center, they immediately feel a difference between our setting and other oncology settings. We believe this is due to the fact that we follow relationship-based care, which is sort of a way of thinking for our patients. And we try to supply our patients with a primary nurse in the settings where they're cared for to guide them through their cancer journey, as well as navigate them from department to department. We've received magnet status at the James, which means that we are identified and have been awarded at one of the best hospital systems in the nation, if not the world, for nurses to work in, because every day we focus on this relationship-based care approach, as I said earlier, which asks us to focus on the patient, the care of ourselves so that we're better at taking care of patients, care of our colleagues, and care of the community. And never has this approach been more important than in the last 2 years, as we have all faced a serious pandemic. Nursing at SSCBC, I believe, is special because of our transformational leaders that take care of us. And you've met 2 of them. You've met Dr. Farr, you've met Dr. Skoracki, as well as our nursing leaders who have led this team to a very high level of excellence. 57% of the nurses at the breast center are board certified in oncology nursing, which is a very high rate when compared to the nation. We have a robust program of professional development and continuing education, and the nurses direct the type of education that they want to learn because we have a shared governance system, which means that they have a lot of control over their practice and advocating for patients and what they need. So let me tell you a little bit about some of the projects that the breast center nurses are working on. We have 2 patient lending libraries in the building. What that means is we've developed lending libraries in the medical and surgical oncology clinics that are open to all of our patients, no matter where they're cared for, where they can sign out a book to help them talk to a child or grandchild about a new diagnosis of cancer. This program was recently highlighted at the National NCCN conference, which is based on the federal guidelines for cancer care. So that was a real feather in our cap. The nurses in the surgical oncology and plastic surgery clinics are part of the state-of-the-art changes we have made to help surgical patients be more comfortable and heal faster. This approach is often referred to as enhanced recovery, and I think some of our surgeons will probably speak to it as well. Basically, this program works to help people get out of the hospital faster, heal better, have less side effects. The nurses help this effort by writing patient education materials with our team. We're conducting a screening project with Dr. Agnes to identify patients with diabetes before surgery to help them heal better after surgery. And we also work on creature comforts, such as surgical drain aprons to ease patients showering after surgery. 2 of our nurses are leaders for the James Innovation and Research Council, guiding other nurses through the research and also the invention process. One of these nurses has devised a novel way to teach patients who are receiving radiation therapy about skincare and designed a garment that holds a soothing dressing meant to heal the rare skin side effects that can occur with radiation. We have innovators here. That's something to remember, not just physicians, but nurses, therapists, etc. The medical oncology and infusion clinic nurses have worked together with our physicians to build our scalp cooling program, which enables a patient to wear a special cap while they're getting chemotherapy to hopefully decrease their hair loss significantly if they're getting a medication that can cause hair loss. This has been a big patient satisfier for our patients. Our nurses are intimately involved in improving the quality of life for patients coping with symptoms, and have helped develop decision trees to manage side effects such as hot flashes, which include interventions which complement the medications that our providers write. Two of our nurses recently published a journal article with colleagues examining limb precautions in breast cancer survivors and offering evidence-based recommendations, which differ from past advice and are based on what our Lymphedema Center of Excellence recommends. Our nurses are innovative, as I said before. Our lead surgical oncology nurse practitioner leads a women's health clinic at the Columbus Free Clinic, which provides care to women who are not insured. One of our nurses was the second nurse to receive a Pelotonia grant to investigate how lymphedema could be detected at home, rather than having the patient come in for a clinic visit. This is in the very early testing stages. We'll see what happens. This investigator has also been awarded partial funding in the form of grants from Oncology Nurses Society and American Cancer Society in collaboration with the OSU Center of Health Equity, with the full support of Dr. Skoracki, to develop brief teaching films in the 7 most common languages spoken by our historically marginalized neighbors in the greater Columbus area. We have the pleasure of collaborating really every day very closely with other organizations concerned about breast cancer, such as the Susan Komen Foundation, Cancer Support Community, American Cancer Society, Pink Ribbon Girls, At the Table, and the local chapter of the Oncology Nurses Society. So in summary, working at the breast center as a nurse is special because we're part of a team who really cares about patients. And our team also allows nurses to dream big and collaborate with our talented colleagues fully. Thank you for this time, and I hope you have a wonderful evening.
Mrs. Brophy, I thank you for squeezing the very highlights of an extremely prolific and exciting group into a mere 5 minutes or so. Thank you very much. The entry point for many of our patients is either a screening or diagnostic imaging experience. And Dr. Hawley, the division lead of breast imaging, will give us an overview of the incredible number of imaging studies that his group performs and interprets from patients throughout the state and, as I mentioned, beyond. And about the innovations that the imaging is allowing him and his colleagues to provide diagnoses well above the national accepted standards. So Dr. Hawley,
thank you. Thanks. I'll also thank you for putting up a picture from back when I started residency, when I still had a little hair in my head. So I don't know where you found that, but thank you. Like you said, I'm Jeff Hawley. I'm the division chief of breast imaging at Ohio State. I'm an associate professor in the Department of Radiology. So I'm just going to tell you briefly about kind of what we do at our breast center in radiology. So I lead a group of currently 9, soon to be 10 radiologists who all we interpret is breast imaging. That is our entire focus. That's what we do all day, every day. And that's something that certainly differentiates us from other groups in the area. We have a lot of data about how well we do in breast imaging. Dr. Skoracki alluded to some of that as well, where we can compare ourselves to our peers around the country. That specialized nature of our care allows us to perform at a level well above what's going on in the rest of the country. Just for example, our screening mammogram recall rate is about 30% lower than our peers all while our cancer detection rate is about 20% higher. So that just is a testament to how well our radiologists are doing in their interpretation and performance. We do a fairly large volume of studies every year. We'll interpret somewhere between 65, probably and 70,000 studies this year overall. Dr. Skoracki also said we do most of our business at the breast center, where we have most of our mammography units, our greatest concentration. We probably have about 22 units, I think, right now throughout the health system for mammography, about 10 ultrasound units as well. We also do have mobile mammography program, which we utilize locally as well as in other more rural and disadvantaged areas throughout Ohio, where we'll travel and performing screening mammography for them as well. One thing, it's great to practice at Ohio State. We are truly comprehensive, I would say, in our breast imaging offerings. We do both screening and diagnostic mammography, screening and diagnostic ultrasound. Our MRIs are some of the best images, in the country, if not, it's certainly in the area, if not the country. We perform all modes of biopsies, ultrasound biopsies, stereotactic biopsies, MRI guided biopsies. Something unique also that we do, we have a large volume of second opinions that we see. That's another way people come in to the breast center. We probably do about, I think, 1,200 formal second opinions a year, which is, I think, a great service that really kind of gets the patient integrated into the center in a fairly seamless fashion. We've been very lucky, and one of the things I really enjoy about practicing at Ohio State, we've been very lucky in the support that the institution and groups like the Spielman Fund have provided in the imaging department throughout the years. We are performing with top of the line technology. All of our mammography units are digital breast tomosynthesis capability. That's basically 3D mammography, which again allows us to have less false positives while finding more cancers. We have offerings that are unique, certainly in our area. We have the ability to perform contrast enhanced mammography, which is kind of similar to doing an MRI, but has some other benefits in being not quite as costly or time consuming. We are just now getting into some artificial intelligence applications in breast imaging, both in lesion detection and decision support for our decision-making processes. So that's exciting as well. And I think lastly, we're also just now on the verge of being able to start offering image-guided treatment options through the radiology department in breast imaging, where we were just on the edge of being able to start offering cryoablation to our patients too, either, which could certainly be a benefit to patients who are not good surgical candidates, and for some of our clinical trial patients as well. So it's kind of a high-level overview of what we do in breast imaging.
Thank you, Dr. Hall. You're extremely proud of, and obviously the technology that's available to you and your group, but much more so the level of expertise that you bring. And thank you for sharing some of those things with us. I'm also excited to introduce our next speaker in the sense that it's somebody that most patients don't get to see, whereas everybody else, I think, on this call, most people get to see, but Dr. Tazbikian and his group tend to be more in the shadows, unfortunately, and it's an incredible group that if you have the chance of spending any time with them, will get you excited about looking under the microscope and learning about the things that we don't see with the naked eye. So if an abnormality is identified on imaging, this may usually lead to a biopsy requiring the expertise of our dedicated breast pathologists, which are led by Dr. Tazbikian. And this is to provide a diagnosis often on the same day, which is really extraordinary. Dr. Tazbikian will give us an overview of some of the latest advances in digital pathology. Thank you, Gary, for participating.
Hello, my name is Gary Tazbikian. I'm a surgical pathologist with a subspecialization in breast pathology. Just briefly, a little bit of information about myself. I earned my MD degree from the Ohio State University. I completed my pathology residency as well as a general surgical pathology fellowship at the Hospital University of Pennsylvania, and then completed a breast fellowship, pathology fellowship at Memorial Sloan Kettering, and then joined the department at OSU in 2013. I'm an associate professor and the breast pathology division director. And my research is focused on therapeutic biomarkers in breast cancer, as well as the application of advanced digital imaging technology in breast pathology. So I'll give you just a brief overview of our service. For those of you who may not be 100% familiar with what we do as surgical pathologists, our job, if you had to boil it down to one line, is we make the diagnosis. So we examine the tissues that are acquired surgically, for example, the breast needle biopsies that might have been acquired from Dr. Holly, who just spoke. We review them microscopically and we provide the diagnosis. Now, all of this occurs sort of behind the scenes, but it's very important because the information that we provide is utilized by the rest of the treatment team, the surgeons, the oncologists, et cetera, to make many of the important treatment decisions for our patients. Now, our surgical pathology services at OSU are fully subspecialized, and that's in contrast to all the other pathology providers in Columbus, as well as pretty much everyone else in Ohio, with the exception of maybe the Cleveland Clinic. And what subspecialization means is that the pathologists at OSU focus or specialize in a single primary area of expertise almost exclusively, and so they're experts in the field. Currently, our division is staffed by 5, and we'll have 2 new additions coming in August, which we're excited to have join. We also support the research mission at OSU. We provide pathology support for numerous clinical trials and studies. The majority of the faculty on our team are very active scholars. For example, in the last 2 years, the top 3 breast pathologists have published a total of 31 manuscripts combined, mostly in topics in breast cancer. So to close, one special area that I'd like to highlight for all of you is our national leadership in digital pathology. And this is really one of the most innovative features of our department, has been the adoption of digital pathology. So what is digital pathology? In a nutshell, digital pathology involves scanning a histologic tissue from traditional glass slides and converting it into a high resolution image that can be viewed on a computer. So it seems pretty simple. But what this technology allows is a whole host of innovations with respect to the acquisition, management, storage, sharing, and interpretation of pathology data. And this allows for improvements in workflow, improved efficiency, quality, and productivity and collaboration. And OSU is a leader in digital pathology, and this started years ago, back in 2017, in partnership between the James, the Department of Pathology, and a cancer informatics company called Inspirata, which led to the investment of a dedicated pathology, digital pathology lab, complete with staff, 10 new scanners. By 2019, we're up and running. 41 of our faculty, more than half, were approved for digital pathology reading. And we were scanning our entire workflow. By that point, we had scanned over 2.75 million slides, which is a lot, and is even higher today. But beyond things like improving speed and efficiency, what's really exciting and amazing about digital pathology is it allows for innovative new avenues for clinical research using artificial intelligence and computer-assisted analysis. And so that's really what makes this amazing. So as one example, right now we're working on a collaborative project together with image analysis scientists, medical oncologists, pathologists here at OSU, and in collaboration with another institution, Wake Forest, on an interesting project called BCR-NET. BCR stands for Breast Cancer Recurrence Score. And basically what we're developing is a cost-effective, practical, deep learning framework, which is able to predict breast cancer recurrence risk from digital path images. So to understand sort of why this is a big deal, I'll give you a little bit of background information. One of the recent advances in cancer care in general, which I'm sure you're familiar with, has been the rise of genomic analysis. And so from this have arisen many different commercial genomic assays, which are used to analyze tumors and identify drug targets and provide prognostic information. And these are all great tools. But some of the sort of disadvantages of these assays is, one, they're very expensive, costing thousands of dollars. They also consume tissue and they take time to perform. Often 1 or 2 weeks. What we're developing at OSU, BCRNet, is an automated tool that uses artificial intelligence and deep learning to analyze digital images of these breast tumors, find patterns and associations that cannot be recognized by the human eye, and provide similar risk stratification and prognostic information as commercial genomic assays, but more quickly and at a fraction of the cost. And because it analyzes just images, it doesn't consume valuable tissue. And this technology has tremendous potential to provide meaningful contributions to day-to-day patient care. And another exciting thing about this technology is that it could be used for healthcare outreach in other countries in which molecular testing is prohibitively expensive and is essentially unavailable to thousands of people. And our results have been very promising. We're in the midst of submitting this as part of a NIH R21 grant application. And so this is just a piece of, a glimpse of what we do in our department in pathology. And I'd like to thank you for your time.
Thank you, Dr. Tosbikian. You make me want to come visit you behind the microscope or behind the computer screen now, even more so. Thank you for that. I appreciate it. Next is Dr. Agnes, the Section Chief of Surgical Oncology and a surgical wizard, representing the next step on the patient journey. And she will give us an overview of some of the many innovations of breast surgeons at the center and also focus on the introduction to our high-risk program. Thank you, Dr. Agnes.
Thank you, Dr. Skoracki. As the others have mentioned, I'm fortunate to work in a center with so many great individuals, not only within my own specialty, but across this spectrum. And I think the teamwork is something that I really appreciate here at the breast center. As a surgeon, we often meet people. It's the first step in their treatment journey after their diagnosis. And often we also meet patients before they're diagnosed when they might have a breast lump or another breast complaint that will lead to their diagnosis of cancer. And so our group, as Dr. Skoracki mentioned, the vast majority of us perform exclusively breast surgery, which gives us an advantage compared to our counterparts in the community who may wear multiple hats. So we can really focus on the care of the breast cancer patients. So our main job is to remove the tumors and to perform a staging analysis by analyzing the lymph nodes. And so we generally perform an excision with either breast conservation or with removal of the breast tissue. And then often we'll do lymph node assessment with something called a sentinel lymph node biopsy. Over the years, we have worked to de-escalate the performance of lymph node surgery because it can have complications, as we alluded to, with lymphedema. And so we have participated in trials to allow that de-escalation to happen and to see when we can safely omit lymph node removal to prevent lymphedema, but also work closely with our plastic surgery colleagues to identify patients who will need lymph node dissections so that we can try and lower their risk of lymphedema. There are some clinical trials being conducted where we're looking at something called axillary reverse mapping, where we inject a blue dye into the arm and try to preserve the lymphatics coming out of the arm when we remove lymph nodes from the armpit to lower the risk of lymphedema. And that's certainly a trial that one of my colleagues, Dr. Park, is active on nationally. We also, when we have to do these node dissections, we'll work with our plastic surgery colleagues, as I'm sure Dr. Cho will address later, to perform lymphovenous bypass in a preventive way so that when we remove the nodes before the patient leaves the operating room, we can try and prevent them from ever developing lymphedema. As a surgeon, we have the advantage of having access to patients' tissues. And one of my colleagues, Dr. Carson, has looked at patients with breast cancer and compared the fat around the breast cancer from the side with the cancer to the side without the cancer to look at the environment around the cancer, not just the cancer itself, to help figure out what drives the cancer. And in his studies, he's found that there are a lot of inflammatory mediators in the fat cells surrounding the breast cancer that allow the breast cancer to develop and grow. And in this work, attempting to identify other targets for treatment to improve outcomes from the breast cancer care. We've also developed an inflammatory breast cancer center and tried to facilitate inflammatory breast cancer is a rare aggressive form of breast cancer that is often misconstrued as an infection. And so we're trying to streamline the process for these rare aggressive tumors so that they can be identified rapidly and gotten into the center rapidly so that we can initiate their treatment in a expeditious manner to improve their outcomes. And this center has already been successful in identifying these patients and improving their care. We also have a number of other colleagues who do research in looking at social determinants of health. Certainly COVID has brought this to the forefront that access to healthcare is not equal for everyone. And so our researchers are trying to figure out what are the things that allow people to access the healthcare system. How can we identify these social determinants of health and intervene to make sure that everyone has access to good healthcare? We also have researchers that are looking at diversity and equity and inclusion across the healthcare spectrum. I want to also highlight our high-risk program. So in addition to working with breast cancer patients and survivors, we work with what I like to call previvors, patients who are at increased risk for the development of breast cancer based on a number of different things. They might have had a number of biopsies in the past that might have shown atypical cells, or they might have a hereditary condition that has increased their risk for the development of breast and other cancers. And so in the high-risk program, we work with our genetics colleagues to identify these patients, do a risk assessment, and determine what follow-up they need in terms of surveillance or enhanced surveillance. And that might be, instead of a traditional just mammogram, we might add supplemental MRI to the screening process to allow us to detect cancers at an earlier stage when they're less likely to involve the lymph nodes. And in certain cases, we might even perform risk-reducing mastectomies with or without reconstruction in concert with our plastic surgery colleagues. As far as surgery recovery is concerned, Dr. Lynn Brophy referred earlier to the Enhanced Recovery After Surgery program, which we affectionately call BRAS for our breast patients. Traditionally, it's thought of as something that decreases the length of stay for patients who generally stay in the hospital for days to weeks, whereas most of our patients are outpatient or relatively short hospital stays. But there are still ways that we can enhance their post-op experience by reducing their pain and simplifying the process so that we can all achieve a better outcome in the long run. With respect to our high-risk program, we've partnered with our radiology colleagues to screen patients as they're seen for their mammograms by asking some questions with the mammotechs about their family history and prior biopsies so that we can use some of the risk calculators built into our system and identify patients who might not know they're at high risk that might benefit from referral to our high-risk program. And so this has allowed us to identify these patients when they may not have been realized that they were at high risk or been referred by their providers. They can self-identify and be enrolled into this program. We're also looking at, with our genetics colleagues, ways of providing care to assess this risk and to provide genetic testing in a more robust and easy manner, because there are not enough genetic counselors to provide the services to the number of patients who might need testing. So we're looking at ways to deliver that with videos to give education prior to genetic testing and then reviewing results after the fact. And so those are just a few of the highlights I wanted to mention about our division. Thank you, Dr. Skoracki, for the opportunity to present this to the group.
Thank you, Dr. Agnes, for this tour de force. I know you wear so many hats. It's difficult to try to ask you to speak about one area. So thank you very, very much. Thanks for giving us this incredible overview in such a short period of time. Dr. White, a world-renowned oncologist and radiation oncologist, will give us an overview of the exciting group and will highlight some of the innovative techniques that she's in fact invented or her group has pioneered with her. Dr. White also leads the breast clinical trials group with the help of Dr. Sardesai, where she truly has the finger on the pulse of the latest treatment advances. So thank you, Dr. White, for participating. You're on mute.
It's the phrase of the last 2 years. So thank you for inviting me. I'm excited to be here. I'm a professor of radiation oncology. And my background comes from the development of novel local regional treatments for breast cancer. And I run clinical trials both here, oversee the clinical trial program here at the James for breast cancer. Dr. Sardesai works with me on this and has been a great new leader for us. And I also run clinical trials for one of the largest research groups, Energy Oncology, and sit on the Breast Cancer Steering Committee for the National Cancer Institute. So it's afforded me a really kind of bird's eye view of what's up and coming in the future. We're a unique radiation center. So we are radiation oncologists. So that means we've all trained for 5 years after residency in oncology, and then subspecialized in breast cancer. We have four right now, but 5 altogether dedicated breast cancer radiation oncologists. And in most centers where you get radiation, you go to a place that has a radiation machine called a linear accelerator. And that you might treat a colon cancer, a breast cancer, a head and neck cancer on those machines. And really just the vision of Dr. Farr, Dr. Schuler, in putting together the breast center in creating one of the only breast cancer specific radiation centers in the country. We are probably, there's several worldwide of radiation centers dedicated just to the breast cancer. So I always tell patients, we speak breast cancer throughout the center. So what that allows us to do is to develop really novel ways of doing new types of treatment and radiation, but it also has allowed us to really improve our craft, in that we have begun, we are well known nationally and internationally for really taking the time to develop these really sophisticated radiation delivery models that maximize targeting dose to what we want to treat with radiation, and avoiding normal tissue around it. And really are well known for this. All of our faculty are invited to speak nationally and internationally on this. I just want to highlight, kind of break it down where some of our more novel programs are and what our research agendas are. And then I want to really move on to clinical trials, because I think that affects all patients in all of our areas here in the breast center. So in early stage breast cancer, one of the best things that radiation does is help women keep their breast. So women who have an early stage breast cancer, they have an option. It's so nice that research has advanced so much that patients have options that are both good. And so they can either have a standard mastectomy without reconstruction, and we have the talent and the expertise to do that. But they can also preserve their breast. And in doing that, one of the things I think I'm proudest of, because I've led these trials across the country, is in the time that I've been practicing, it used to be, if you wanted to preserve your breast, you had 6 weeks of radiation, Monday through Friday, 5 days per week. Through a series of trials that we have published in very high impact journals, we have demonstrated, and really, and thankful to nearly 8,000 women randomized in trials here in the United States and internationally, we now know that we can treat a woman who wants to keep her breast in most subsets in under 3 weeks. And in one portion, we can treat just part of her breast for 5 treatments, and she will still get an excellent local control compared to what was in 6 weeks. This has been a really, I think, an important thing to reduce the burden of care on patients so that they can get back to work, they can get back to their families. And these are trials that we've conducted here at the Breast Center, and really are proud of what we've accomplished. We're still working on that, though. We really believe we can use the new genomic assays like the recurrence score to find that woman who, when she gets a lumpectomy by Dr. Agnes, she's done. She doesn't even need the radiation. So we are now just opened up. It's a trial that I lead nationally, and it's open here and across the world to find about nearly 2,000 women who, if they have a low genomic score on their cancer, that they may omit their radiation altogether and still have great cancer control. And we're really optimistic we'll still find that group of women that they don't even need the radiation to have good outcome. For locally advanced disease, we're working with our colleagues here in combining radiation with drug therapy. In inflammatory breast cancer, one of our radiation oncologists leads, I think, one of our only clinical trials right now in inflammatory breast cancer, combining a PARP inhibitor with radiation that's delivered. We have another trial where we're looking for combining a very novel agent with a radiation for women who have multiple positive nodes. So in using all of our talents here in the across the breast center, we're developing trials that combine medications and surgery techniques and radiation to maximize cancer control and minimize the toxicity. We're also excited to have worked with our surgical oncologists to know when we need to escalate surgery and when we can de-escalate surgery in the underarm area, because we can use radiation instead and get the same cancer control and save the risk for lymphedema. So it's been very nice to be able to work collaboratively to not only take care of patients, but to ask really good research questions. I'm going to move over from the radiation portion and talk about clinical trials here at the Breast Center, because all of us, everyone on this phone, on this call tonight participates in these. Right now, we have 39 active trials. We have 50 active patients receiving treatment on a trial and over 300 patients on breast cancer trials for who we're seeing regularly. Patients, we have clinical trials that have every modality involved, from screening to surgery through radiation, numerous therapies, particularly systemic therapies, from early stage all the way through metastatic stage. For patients who want phase 1, 2, or 3, we have surgeries, plastic surgery trials, and then survivorship trials to kind of quantify and see if we can improve the patient experience after treatment. And I just want to say that up until recently, before the pandemic, about 25% of our patients were going on a clinical trial and supported to do so. And that's really a tremendous thing for the next generation of breast cancer patients, so we can answer those questions. And so we're happy to, I think all of us have trials that we're involved to, and if I can answer any more questions, I would love to, so we can tell you all the exciting work that's being done here across the entire center. So thank you very much for the opportunity to talk tonight. I really appreciate it, and happy to answer any questions afterwards.
Thank you, Dr. White. And I can say without any doubt that to have your radiation delivered here, you are going to get the very best in the world, thanks to you and your team. So thank you for all that innovation, and thanks for continuously pushing the envelope both locally and nationally with the research and research oversight that you provide. Thank you very much. I'll move on to the plastic surgery department. I'm going to challenge Dr. Cho to try to get us back on track. I'm sorry, everybody, we have too many exciting topics. Dr. Cho, an expert microsurgeon, is going to talk a little bit about the offerings of restoring form for our patients, but also about the treatment and maybe prevention of lymphedema. Thank you for being with us tonight.
Well, good evening, everyone. My name is Minjung Cho. I'm one of the plastic surgeons at the James. And as Dr. Skoracki had mentioned, I would like to discuss our breast reconstruction and lymphedema program. So whenever Dr. Agnes and her colleagues remove breast cancer, either through lumpectomy or mastectomy, we will help patients through their breast reconstruction journey. So for the patient who undergoes lumpectomy, we'll rebuild the breast by reusing the remaining breast tissue by creating youthful breasts or lifted breasts. For patients who need a total breast reconstruction after mastectomy, we could use implants, or the patients who want more natural form of breast reconstruction, we could use what we call a TOS breast reconstruction. So we will typically take skin and fat and blood vessels from their abdomen, and then transfer the tissue to the chest, and then hook it up to the chest blood vessel using a microscope. So the suture that we use for the microsurgery is about the thinness of your hair, so you can see how small these connections are. And then this form of breast reconstruction, it is fusing the abdomen, is widely offered around the US, but we have a complex autologous breast reconstruction program where we'll use the thigh or flank tissue, or sometimes at both abdomen and thigh, to rebuild the breast. And then this is only offered in very few centers in the US. And for the patients with a severe breast cancer, as Dr. Agnes and Dr. White has mentioned, they will have their lymph nodes removed as a part of their treatment. And they could have what we call lymphedema, which is chronic swelling of the arm. And for those patients, we will rebuild their lymphatic system. So we will try to prophylactically avoid having the lymphedema buildup. So that's called prophylactic lymphovenous bypass, where we find the lymphatic channels and then we will microanesmosis to the veins using supramicrosurgery. And for the patients who already have a lymphedema and then they're in the early stage, we will perform lymphovenous bypass in their arm. And for the patients who have a more severe lymphedema and they're not a candidate for lymphovenous bypass, then we will transfer lymph nodes for the abdomen and then to the axilla. So we're rebuilding the lymphatic system. And we are, as Dr. Skoracki had mentioned, we're one of the very few centers actually in the world that's recognized as excellence of a lymphedema. And for the patients who need both breast and the lymphedema reconstruction, we will perform both aesthetic and functional restoration of the breast. So thank you for the opportunity to talk about our breast reconstruction and lymphedema program, and I'm happy to take any questions at the end. Thank you.
Thank you so much, Dr. Cho. Record time also because Dr. Cho already completed a bilateral breast reconstruction with the transplant from the abdomen earlier today. So thank you very much for making time for us. Next up, we have Dr. Williams, an expert medical oncologist who probably should have been introduced earlier in this virtual patient journey through our center, as chemotherapy is frequently used as the very first arm of treatment. However, one of the many areas of interest of Dr. Williams is our breast cancer and aging resiliency or care clinic that will guide patients well beyond the initial encounter. Thank you, Dr. Williams, for giving us a closer look into innovation and discovery within medical oncology. Thanks for being here.
Thank you so much. It's my pleasure tonight to highlight some of the exciting work being done by myself and my colleagues in medical oncology. I'm one of the soon-to-be 10 breast medical oncologists at the Breast Center. And then, as previously mentioned, we see all stages of breast cancer from early stage to metastatic disease and offer treatment with systemic therapies such as chemotherapy and endocrine therapy. Our group's research interests are varied and they span from prevention, treatment, survivorship, and management of advanced breast cancer. We also have a breast medical oncology fellowship in which our graduates have stayed on to become faculty here at the Stefanie Spielman Breast Center, as well as at other academic institutions nationally. Tonight, it's my pleasure to highlight some of our collaborative programs. The first one I wanted to mention, as Dr. Skoracki mentioned, is the Breast Care Clinic, in which I am the program director of. The Breast Care Clinic is a multidisciplinary clinic for patients 70 years of age or older diagnosed with breast cancer. The multidisciplinary clinic consists of myself, an advanced nurse practitioner, a nutritionalist, physical therapist, and pharmacist. During every patient's initial visit, they receive a comprehensive geriatric assessment. The comprehensive geriatric assessment evaluates physical function, cognitive function, other medical problems such as COPD, polypharmacy, nutrition, and social support. We feel like the value of the comprehensive geriatric assessment is important because national guidelines do recommend a comprehensive assessment for any patient over the age of 65, because this assessment identifies deficits that are not picked up on typical oncology assessments. We also follow older adults during the course of their cancer care and will perform a comprehensive geriatric assessment every 6 months to identify any deficits that have occurred during the course of their treatment. We also offer clinical trials specific to older adults with breast cancer, which is a patient population that has been underrepresented in clinical trials. A second program I wanted to highlight tonight is our Living Well with Advanced Breast Cancer Clinic, which is led by Dr. Ashley Pariser. This clinic was first established in 2017 and is a comprehensive personalized consultative visit currently offered to patients with advanced breast cancer. Patients and their caregivers meet with specialists in breast medical oncology, integrative medicine, palliative care, nutrition, and nursing. They receive disease-specific education, including a discussion on biomarkers, tumor biology, and the role of research in clinical trials, as well as available supportive care services, which was highlighted by Ms. Brophy earlier tonight. We also host an annual Ask the Expert conference for patients with advanced breast cancer annually, which we held this past weekend. And it gives patients the opportunity to learn about updates in the management of advanced breast cancer. The third and final program I wish to highlight tonight is our immuno-oncology program, which is led by Dr. Margaret Gaddy-Mays and Dr. Robert Rozlowski. The purpose of our immuno-oncology program is to embrace immunotherapy as a component of standard of care through opening innovative immunotherapy clinical trials, through collaborations with our Palatonio Institute for Immuno-Oncology, and we also develop guidelines for expert management of immune-related adverse events with a focus on survivorship. There are two clinical trials that I wanted to highlight tonight from our immuno-oncology program. One is a trial looking at cryoablation plus immunotherapy in residual triple-negative disease after neoadjuvant chemo. And this is a collaboration with University of Texas Southwestern and Cedars-Sinai. And the second is an NK cell trial with chemotherapy in advanced breast cancer, which is a collaboration with Nationwide and then the Palatonio Institute for Immuno-Oncology. Thank you so much for listening and learning about some of our exciting collaborations that we offer here.
Thank you, Dr. Williams. Like all of our groups, you can see there's a plethora of incredible innovation going on, ideas and research. Thank you for everybody so far for distilling it into these tiny little aliquots of time I've given you. Next, representing our many dedicated and specialized advanced practice providers, I'm excited to hear from Rashay Hatfield, who will talk about an exciting area dedicated to quality of life well beyond the active treatment of breast cancer. She's an expert in cancer support or survivorship. Thank you.
Thank you, Dr. Skoracki. As you said, I'm a nurse practitioner. I have the privilege of working in cancer supportive care clinic, also called Survivorship. We actually have two locations for our clinic. We have one at the Martha Morehouse Tower that serves pretty much every other cancer disease line besides breast cancer. And then we have a location integrated within the breast center that specifically serves our breast cancer survivors, and that's where I'm at. Most of the referrals that come to us are from a patient's primary oncology team, and a lot of those come at the end of treatment, although patients can be referred to us at any time from the time of diagnosis, even through long-term follow-up. And patients are actually also able to self-refer, so they don't have to have a referral to be seen in our program. When a patient comes to see us, we really take a very sort of comprehensive and holistic approach to evaluating whether or not patients having any sort of cancer-related distress, and just whether they have any outstanding supportive care needs. And how we do this, we ask the patient questions that are about whether or not they're having distress and how much in multiple sort of areas of their life. So not just the physical aspects, because we know cancer doesn't just impact people physically, but asking about how they're doing emotionally and mentally. Do they have any spiritual concerns, any social practical problems, any health related concerns, any changes in their cognition as a result of treatment. And then we'll also ask specific questions and inquire just about sexual health, about nutrition, about any concerns with substance use like tobacco or alcohol, how their families are coping, if there's any concerns with things like that. And based on kind of just this thorough discussion, we're able to make specific recommendations for supportive care resources and programs that we offer. Also, as an important component of survivorship, we talk to patients about their health habits and provide education on healthy lifestyle recommendations. So we have a pretty robust supportive care service line, offer a lot of different programs to patients. We have an adolescent young adult program. So that's consultation with an adolescent young adult social worker, specifically to talk about the unique supportive care needs and perform an assessment for our patients that are diagnosed with cancer under the age of 40. We also have support for male and female sexual health. We have a cardio oncology program, so consultation for oncology treatment related cardiac side effects. We have a fertility preservation program. So we have a nurse practitioner who will meet with patients who are still of an age where they're fertile and they might be undergoing a treatment that's going to affect their fertility. So just talking to them about family planning, how to preserve that. We have an integrative oncologist, a consultation with an integrative oncology physician to talk to patients about complementary approaches to wellness, so talking things about nutrition, sleep, stress management, and make recommendations for referrals to things like massage, acupuncture, meditation. oncodermatology, so consultation with a dermatologist for sort of side effects, cancer treatment that affects things like skin, hair, nails. Oncology rehabilitation, so things like physical and occupational therapy. I know Karen's going to talk a little more specifically about that, but that's a really important service that we refer a lot of patients to help them manage things like fatigue, imbalance, or fine motor problems that come as a result of neuropathy from their chemo, to help them develop exercise routine. So there's sort of a collaboration that's offered between physical and occupational therapy, a fatigue management program that helps people sort of help with energy conservation and developing exercise walking program. Palliative care. We have a very good psychosocial oncology group that offers individualized counseling to patients as well as to caregivers, helps with psychiatric medication management, art and music therapy, harm reduction for substance use. So folks that are maybe wanting to eliminate use of tobacco or cut down alcohol use, grief counseling, and then our James Care for Life program. So these resources provide free supportive care programs to patients, their caregivers, their families, and focus on things again like nutrition, exercise, mind, body, spirit, offer expressive art support through art and music therapy programs, our cancer support group. So we have a breast cancer support group that meets on a monthly basis. We have a peer matching program called the HOPE program that matches a patient or caregiver one-on-one with a peer person with a similar experience to provide that one-on-one support. So a lot of amazing programs and support services that we offer. Another thing that is really important that we do for a lot of the patients that we see in our clinic, a lot of patients, as I mentioned, are being referred at the end of treatment, a lot of times very close, they've just finished active treatment. And we provide them and construct for them a very individualized document called Treatment Summary and Survivorship Care Plan. So this gives sort of a brief summary and outline of their cancer treatment, kind of the pertinent things, how is their cancer diagnosed, what kind of surgery, the pathology, the names of the chemo drugs they got, how much radiation was delivered, and then also allows us a chance to just go over and talk about survivorship care. So that's things about, what's the recommended frequency or interval and duration of follow-up with your oncology teams, what are the surveillance tests that may or may not be recommended, what are other recommended age-appropriate cancer screenings or other health and wellness tests, and then coordination of that care, kind of who's responsible. A lot of patients really appreciate that because they haven't really thought much about kind of what comes next. They've been very focused, as they should be, on just getting through their treatment, kind of on what's next. And so they appreciate being able to kind of look forward. And then we do spend a lot of time just kind of focusing on what are good health habits that can impact survivorship. So, whether that's just avoiding tobacco and alcohol, or alcohol in very limited amounts, really encouraging patients to engage in some regular exercise, talk about what good nutrition looks like. And then we'll work with patients to develop a goal or two for themselves just to optimize and improve their wellness. So I feel like just kind of overall, this helps improve patients' quality of life by that ability to provide some counseling, get them linked into resources that can help manage side effects of treatment and provide education on those good health habits that can help to optimize overall physical, mental health, which may impact helping to reduce their risk of cancer recurrence or development of other cancers in their life. So thank you.
Thank you, Rashay. We're so excited to have all of these different programs because obviously I think we all believe in treating the whole person. And while that happens, I think in every one of our clinics, it's wonderful to have these dedicated experts that really round out the experience, as Rashay mentioned, improve the quality of life of each of our patients, and also take into consideration the patient within their environment, the family environment, their larger community, and how we can help them kind of stay integrated and optimize their role in those communities. So thank you for all of those things. Rounding out the evening then is Mrs. Karen Hawk. She's the lead for our rehabilitation services on an outpatient basis. She's a nationally recognized expert and will share with us some of the many techniques that her group will bring to the active treatment and also the long-term recovery of breast cancer patients. Many of the services are available only in select centers around the world, and our team is certainly a leader in the care of lymphedema. Thank you, Karen, for being here.
Thank you, Dr. Skoracki, and thanks for the opportunity to speak. I'm very honored to talk about our oncology rehab department. I could talk about them forever, but I won't. We are a specialized group of oncology therapists, occupational and physical therapists who specialize in the treatment of the patient with cancer. Our goal is to help patients optimize their quality of life, no matter what point in their cancer journey they need us. So, excuse me. So think about us at the beginning, the middle, anywhere along the way. That's where we can be helpful for patients. We're a pretty robust department. At all of our oncology rehab sites, we see about 1,100 unique patients per month. About 700 of those patients are at the breast center. We have a team of certified lymphedema therapists. We have 12 physical therapists that are specially certified in treating lymphedema. We work very closely with the plastic and microvascular surgeons, with Dr. Agneson, the surgical oncologist, with Dr. Williams, with Roche. That's one thing that makes our team so unique, that PT and OT don't always have that opportunity to work that closely with all of the members of the team. And I didn't want to forget Dr. White, because we've done studies with Dr. White and her group as well. Some of the things you're probably used to hearing from physical therapy and occupational therapy are things we do also. The side effects of cancer and cancer treatment, we want to try and reduce those effects. So range of motion, weakness, fatigue, cognitive dysfunction, peripheral neuropathy. Roche talked about some of this, gait and mobility, reducing risk of falls. We have 3 therapists now that are trained in female pelvic floor therapy. And we're very excited to offer that to our patients. We work with Dr. Williams in the oncogeriatric clinic. We have our James exercise program, which was a specialized exercise program to help patients return to their exercise programs. We know there's a recommended amount of exercise that we all should get, and that holds true for our cancer survivors as well. And this program helps people get back to exercise in whatever setting is best for them, whether it's the home, outside, at the gym, now that we can do that again. And we can meet the patient wherever they are. If low functioning, high functioning, sometimes our high functioning patients need that assistance too, to gain that confidence back that they can do the exercise and activities that they did prior to their diagnosis. I'd like to highlight our James Oncology Rehab Residency. It's one of only 6 in the country. We have an oncology physical therapy resident each year. The mission of this program is to elevate the practice of oncology rehabilitation, which improves the care for our cancer patients. It's also educating the future therapists that will be working in this field, and it keeps our therapists working at the top of their scope. So we're very proud of that program. Our team's involved in clinical research with all the people that you see on the screen. We have a national presence at meetings around the country, presenting platform presentations and posters. One of our collaborations that we're very proud of is the Oncology Rehab Conference that we sponsor, and we do that in collaboration with the University of Michigan. It's a very nice collaboration with them. So thank you for this opportunity. We want to continue to strive to take excellent care of our patients, and we'll do that with all the people that are on this call.
Thank you very much, Karen. I think I speak for all of us on this call that we are incredibly grateful to you for really allowing our patients to regain their kind of physical prowess or physical, not just strength, but I think you do so much for our patients in terms of their recovery and in terms of the prehab even before recovery. So thank you very, very much. Thank you for sharing many of those programs. I want to thank everybody here for all of your input. It really is a team effort. I hope we've demonstrated that tonight. I'm grateful to be working alongside each one of you. I'm going to open up the event to audience questions. I'm sorry I've not been the greatest steward of time tonight. So I'm not sure how much time we do have for questions, but I will open it up for a few questions, and I will assure you that any questions that you will post, we will try to follow up. And please also feel free to contact us, and we're happy to answer any additional questions. So I'll look in our chat function here and see what questions have been posted. I'm going to lean on Jamie to help us out. And I'm probably looking in the wrong spot in my chat box here. We have a question. Wow, that's a that will take another hour, I think. One of the questions is, how does philanthropy impact your work? I will make a very brief comment, and then I'll punt it probably to Dr. White. My quick comment is it makes it possible. I think philanthropy is one of the major pillars that allows us to be the innovators that we are, that allows us to push that envelope, that allows us to care for patients and every aspect. Very much also what Ms. Hatfield said, this is not only directed at the clinical research or the research at a molecular level, but allows us to do all the things we do for the total patient. Dr. White, and feel free to punt that along, because I think all of us are affected by that question.
Yeah, I just want to echo that. So philanthropy, from simple things like access to getting into the breast center, to getting the most up-to-date imaging, to how to the type of what your waiting rooms look like, how we're able to support services specific to breast patients' needs. Our early phase trials, our young investigators who come in with these phenomenal ideas and do research anywhere from basic research through clinical trials. Philanthropy has had an impact on every piece of that along the way. We wouldn't be able to tell you such a great story or such a great success without it. It really touches every part of our patient's journey and the journey of the patients of the next generation, because that's really what research is about, is how do we treat the next generation. So I can't thank everyone present so much. We're grateful. I guess that would be the one word I would think all of us would share with you.
Thank you, Dr. White. And I know we're way over time. So in the interest of to be I guess, a steward of everybody's time, thank you very, very much, everybody, for being here. Please, if you have additional questions, contact us, send them in, place them in the chat. We are more than happy to respond. We would love to hear more from you, and we would love to share more with you. By way of closure, I guess, thank you for spending your evening with us, and to all of my colleagues for providing us with new and exciting information to share within our networks. We hope that this journey through the various specialties has given you an idea of the depth and breadth of expertise available at the Stefanie Spielman Breast Center, and more importantly, of the absolute must for this very multidisciplinary approach, requiring the assembly of all of these experts focused on the care of each patient. And in fact, I think there were many more experts behind the scenes that I didn't have time to mention, or that we, in the interest of time, couldn't include. And I don't want to discount that at all, because it takes many more people to make this happen. We hope that everything that we've heard this evening has given you a better understanding of how the breast center operates and what sets our program and hospital apart from other centers. We also hope you will join us at the Step Up for Breast Cancer in October, for which you'll receive more information in the follow-up email. Thank you for continuing to stay informed, for your interest. We hope to see you all at upcoming events, and please reach out to all of us to learn more. Stay well and take care. Thank you very much.